Hello and welcome back to Balance and Hormones video. We've got Dr. Touliatos with us again this week. We've got lots of questions people have put in for him to answer.
Hello, Balance and Hormones.
Touliatos, we introduce him every time. He's a biopathologist. He specializes in looking after men who have affected themselves with anabolic steroids, performance-enhancing drugs, but also men that need hormone therapy. And he also lectures on, management of reducing risk with performance-enhancing drug use, things like that. So this is his book, one of a few books. Bodybuilding, the Good, Bad and the Ugly, so you can check that out online, full of lots of useful information. Obviously I'm here with Mike.
Hi George, good to see you.
Yeah, thanks
Sam
thanks for coming on. How you doing?
I'm fine. I just got from work, so let's do the second video of the series, and actually the third one, because we have already done a video in Athens.
Yep, absolutely. Right, so should I start the questions we've got?
Yeah, sure.
Okay, so we did touch on this a little bit last time, but someone asked again. So how do I find out if I'm suitable for TRT?
How do we? Sorry?
So as a patient, how do I find out if I'm a suitable candidate for TRT?
Yeah. Well, you have first to do an HPTA assessment evaluation of the lab work, so including hormonal evaluations, which is LH, FSH, total testosterone, free testosterone, beta-estradiol, prolactin, HCG, and DHEAS. And of course, we need also to verify with the clinical data in the physical examination and the medical history, the symptoms, so we have to match the lab work along with the symptoms. And we have to both to be positive in order to proceed into HRT.
Okay.
So we don't just treat labs and numbers, we have to make sure that there are also symptoms of hypogonadism, so which is foggy mind, which is erectile dysfunction and low sex drive and low self-esteem, and or mental fat, visceral fat accumulation, and fatigue and muscle weakness. All these show that this guy has low testosterone levels, low gonadal axis.
Okay, so it's blood work and symptoms and
yes. Blood work has to be taken in the morning, because supposedly testosterone is higher in the morning, and afterwards we take the medical history.
Mm-hmm.
Also if any drugs come into play, and poor lifestyle.
Mm-hmm. The history, medical history.
Yes.
You particularly might be steroid use as well, particularly might be an
other drug use, auxiliary drugs and or recreational drugs, narcotics, or alcohol, or insomnia and stress, and barbiturates, codeine, and even cortisone, antacids, a lot of medications.
Okay, so that's where you'd start. You'd get some blood work. You'd probably speak to someone.
Yes. And also depends, if somebody's at the lowest optimal levels, then we have to check out, according to the doctor who treats this patient, then we have to check out his lifestyle. If he's a bachelor, if he's somebody who lives, who works a lot of time, and his lifestyle is very demanding, then I believe he cannot go on and live with 300 testosterone, unlike somebody else who's a monk, for instance, and has no challenges, and he can live with 300 testosterone. But anyway, low testosterone is not good for the heart, for diabetes, for metabolic syndrome, so there comes more, it is worse to stay hypogonadal than to go on testosterone in case you need it.
Okay, great. So the next question we've got, it's good we've got Mike here. Is hair loss guaranteed on TRT?
Excuse me?
Is hair loss guaranteed?
Listen, we answered this before. I think it's purely genetically predisposed, okay? The temporal lobe, so androgenic alopecia happens to all men, and after the age of 30, or 40, it starts going inside here, the temporal lobe, losing hair and also occipital. But if you are predisposed, it's going to be accelerated. All right, so if you are going to lose your hair at 50, maybe you're going to lose it at 45 or 40. But you want, it's inevitable to avoid your DNA. But however, there might be some cases using 5A reductase inhibitors like finasteride or dutasteride, or some other local agents like ketoconazole or minoxidil that may prevent DHT, testosterone reduction of DHT locally in the scalp. However, if you use finasteride or dutasteride, which is more potent, then you're going to have the post-effect syndrome, like John Cruz has mentioned, which is depression and low sex drive, because actually they castrate you, those drugs. However, they save your scalp, you know, which is contradictory, one against the other.
Yeah. Well, when I was younger and I had to make the decision between, you know, having a good, healthy sex drive and libido, or having a full head of hair, I was starting to lose mine in the 30s, and my maternal grandfather did have a full head of hair. I realized that it's probably better to have a good functioning sex drive, and it hasn't seemed to slow me down at all, having to shave my head. So it was probably the best thing that I could have opted for. But there are a lot of men who are distressed about the possibility of losing hair. And you're right, we've seen people who have some genetic predisposition that it may happen a bit earlier on TRT, but then they'll also get the benefit of improved libido, improved health and wellness. So
perhaps bald people in first place, without touching any androgens, have higher DHT and higher sex drive in first place. Okay, so without using any testosterone or any androgens, those bald people from 30s, maybe they have higher reduction of testosterone into natural testosterone into DHT, and perhaps this affects their sex drive, and they are, you know, more sexually irritated.
So you think maybe, like in my case, I always needed to have more testosterone and DHT, and when it started to go down, only by replacing it could I feel fully optimal. And then yes, that high amount of DHT and the genetic predisposition caused the hair to fall out, but at the end of the day, I still needed to have a high amount of DHT to maintain what I probably had before as far as other function, sexual function.
Yeah. You know, there's a specific group of people somewhere in Puerto Rico, I think, that they do not have DHT at all.
Really?
And they have small penis, and yes, their sexual characteristics are very low. Patrick Arnold told me that once. And it's because there is no 5A reductase enzyme. Wow. So they do not reduce testosterone into DHT, and they have no, you know, facial, you know, they have no, you know, the hair growth, but all in the beard and the mustache and the, you know, in the back. And but also they do not have this kind of positive effect of DHT on sex drive and libido. Yes. And they do not develop benign prostatic hypertrophy, you know. Also,
I mean, I definitely shave my head if needed, and I'd rather take that, you know, avenue with testosterone.
Well, there are some statistics that say that bald men are, you know, are hornier to, you know, they say natural, like who's this actor, you know, Jason Statham.
Yeah.
Or Bruce Willis, you know.
Yeah, that's cool.
I can attest to that.
Yeah, yeah. You're the evidence. So got these ones as well.
So George, Dr. Touliatos, how, in general, I mean, you and I know this, but for the people who are maybe new to TRT, how is TRT normally administered? I mean, what is it? Injections?
No, we have different types. We have 3 basically, so 4. Actual, maybe 5. We had the buccal, we had the pellets, we had the transdermal, but the most common is and we had also the peros, but the most common is the injections, and still the transdermal. They work different kind of applications. So we had the pellets, we had the buccals, we had the orals, we had the transdermal, and we also have the injection, which is more familiar and the commonest. Personally, I have used 3 of them, the orals, which is the Restarol Andriol, along with transdermal, but also I'm using now the injections, okay, since 2015 for the past 5 years. The advantages of the transdermal and the peros are the frequent administration, the daily use, meaning that you have steady levels. Now, the injections have this kind of fluctuation because they spike, and then the day before the injection, you're supposed to have some lower levels, and you can administrate your HG before your next injection, in order to elevate your levels, as Chrysler and Dr. Saya stated. And also you have the long-term, the buccals and the pellets, and which are surgically induced into your glutes, and the buccals into your gums. But I find the best for me, the injectable, because it gets directly into the bloodstream, I do shallow intramuscular injection with an insulin syringe in my delts, either every day or every other day, or maybe 3 times a week. And yes, it's the cheapest because the transdermal, we have to admit that it's more expensive, it's more convenient though. Now, transdermal, they apply it either in the forearms where the skin is super thin, and then we rub the forearms together one against the other. We don't apply them obviously in thighs or in the shoulders because the fat is not low there. And also, it's more common now, it's more trendy, the scrotal apply, where the skin is super thin in the scrotum, and we have also a wide vascular network of veins, which is called the pompeian plexus, and is rapidly absorbed through there, the transdermal testosterone. However, I have heard that transdermal testosterone is only 10% absorbed and then 90% is wasted. But anyway, we have to check the levels. And personally, when I tell to my patients to use transdermal testosterone, I tell them to apply it AM and PM. So twice a day in order to have more steady levels every 12 hours. And we check out, yes, the levels, the serum levels. I had a plastic surgeon as a patient of mine who wanted in his mid-50s to be more sexually active, and he told me that the cream, unlike the injections, will make him more edgy and hornier than the injection. And I assume that skin has higher percentage of receptors of 5-A reductase enzyme. Therefore, it's beneficial for the sex drive applying the cream, but also make you more, aggressive.
Okay, so you felt a bit more assertive, a bit more on edge sort of thing with that.
Well, I believe this is person to person, but some people find it more beneficial for the cream. I had also this question on Dr. Testosterone on the muscular development, that the creams makes you, hornier, but also kind of irritated also. And I'm guessing it's due to DHT.
Do you think it might also be due to the elevated estradiol and DHT at the same time, rather than it being one or the other?
Sure, but estradiol, why in particular to elevate through the transdermal? Is there any certain reason for that? Or hypothetically, if we have a higher estradiol, then we may have mood swings.
So yeah, the mood swings of high estradiol and the DHT may be...
Yes, both, and because estrogens, they can affect the male's mood,
Exactly. Then the extra aggression or the drive from the DHT may contribute to that aggressiveness.
But then also, it's key, isn't it? I mean, we need DHT as men.
Yes, of course we need. The DHT is not a villain. Actually, testosterone is a pro-hormone to DHT, and DHT is responsible for all the benefits of testosterone in the mental sphere, in the sex drive, in the self-esteem, in the cognitive function. But also we have the enlargement of the prostate and the losing of hair. But again, this is according to the person. It's not one size does not fit all. So I never had androgenic alopecia, and my PSA is below 0.5. All right.
Good.
But however, I'm prone to erythrocytosis.
Okay, so there's always something. What ester, or what do you think the best ester for an injection would be, or the type of ester or combination of esters?
Well, different countries and places around the world use different esters according to the pharmacy. Now, in Greece and in Europe, generally we use the enanthate. In the States, they use the cypionate. In the UK and Australia, they use the cystanol, which is a blend. Now, if you know what to do, then there's no problem with any kind of ester. Personally, I find an advantage of the system. Why? Because it gets rapid to the system with the propionate ester, and then the next day, the following day, you have a peak on the levels through the propionate ester, unlike the enanthate that has to peak around the third or the fourth day, and then it crashes. Also, if you use the system for other purposes like bodybuilding, it has the benefit that it still remains through the undecanoate ester in the system. So it gets both fast and it leaves slower. Okay, so it's different speeds, but you can get advantage of this with the propionate, feeling very good in the very beginning, and then it doesn't crash rapidly which is the enanthate is a faster ester, or just using propionate. Because system has also the antidepressant, which resembles the libido. Now, also we have the libido that is super slow. I have a couple of patients that using libido, and frankly, they wasted their first 6 months, the first 3 and the other 3, by using 2 shots of libido, so 2 grams of testosterone, without remarkably elevated their levels. So they had a 350, and they had already used 2 grams of libido. This is crazy.
So pretty much unless it's libido, if you're using any of the esters, as long as you adapt it to the patient, I suppose, and know what you're doing.
Yes, and libido on the other hand, it has the disadvantage that you introduce a huge amount of testosterone that will spike on estradiol and on aromatization, and also on DHT, that it will also affect erythrocytosis and hematocrit. But this is a very slow vehicle that it will open up the speed after 6 months. This is crazy. I mean, it costs 100 pounds, and you waste your money, and you still don't feel anything remarkable.
Yeah, I've definitely seen guys on libido that were a doctor was giving them libido and then giving them a therapeutic phlebotomy every 4 weeks.
But it's still convenient for those people who are already they have used libido for a couple of years, and they do their shots every 90 days. It's very convenient for them because they're not familiar and they don't like the frequent protocols,
So it's a personal thing, really. That's cool. Okay. Next question. Mike's got my here.
So if you were to prescribe injections, can people be trained to do self-administration? And would you recommend the glutes for the intramuscular injections?
Yes, personally, I started when I first started using testosterone in 2015 as a TRT protocol. I did deep intramuscular injection. It was a kind of problem for me. Afterwards, that I went into the frequent protocols, then I realized that the smaller doses cannot be administered with small syringes. The one we have in Greece, the smallest is 2.5 ml, but still, half ml is a lot. So the tiny micro doses can be adjusted convenient only with the insulin syringe. Now, the insulin syringe has a very small needle that can be intramuscularly administered in the delts, because in the delts, we don't have so much fat, okay? Unlike, for instance, the butt, the glutes, and the stomach. However, if some people wish to go for subcutaneous, they can still use it in the stomach, or in the glutes with an insulin needle in order to do subcutaneous. John Christie used to say about the subcutaneous that the advantage is you don't have this kind of scar tissue as you have in deep intramuscular in the butt or the ones in the shoulders. But personally, I find it creates kind of lumps because you inject oil into the fat. And of course, we know that oil needs a couple of days to be dissolved, Unlike the peptides, for instance, HCG or human growth hormone, that they're water-based and they don't create lumps in the subcutaneous tissue. And in the lab work, I haven't found any substantial difference between the serum levels, either subcutaneous or intramuscular. But I do know it's a fact that intramuscular gets faster to the bloodstream rather than the subcutaneous, that it's poorly vascular supplied. So then it gets slower into the system.
I also think we talked about this before. I think the European preparations that we have tend to just not suit subcutaneous use in a lot of people. So that's why I think, in America, they can compound different mixtures, different oils into their testosterone and find one that works for you subcutaneously. We have our pharmaceutical made products that a lot of them tend to just cause these lumps and bumps, like you said.
Yes.
I mean, we've had lots of reports on testosterone when those patients had tried subcutaneous injections, either inadvertently or deliberately, and they would call and complain of these lumps, these bumps, and we would also see very strange levels. They weren't as predictable as you could normally see on an intramuscular injection, of testosterone. So I know Dr. Chrysler, late Dr. Chrysler, he had popularized the idea of subcutaneous injections of testosterone, and he used to talk about the scar tissue. But you as a biopathologist, I mean, what's the functional problem behind scar tissue? Would it only be relevant in the event that you were a cadaver being studied by medical students to see? Because I mean, the scar tissue isn't seen through the skin, is it? You're talking about a potential.
Well, there's no significant scar tissue. I never experienced that for the rest of 2 years that I'm using, and it's a fact. It's a pain in the ass,
But how serious is the scar tissue? I've been injecting for over 20 years, and this
is intramuscular in your glutes.
And I don't, in my glutes, right, left, every 5 days. And there's no functional problem with my glutes. I can walk, there's no pain, there's no...
the thing
have
is,
you noticed any kind of scar?
No scar on the skin, no scar underneath, no fibrosis.
So do you switch to your glutes?
I switch glutes, but I think when they've spoken about this scar tissue, it has put a lot of fear from, as medical case managers, we'll have people will talk about this. And I thought maybe it'd be important to kind of, let's step back a minute and say, what does that really mean? What is the dysfunction that occurs if you, so what you've got scar tissue? Is it immobilizing people?
Yeah, well, I think, coming from my background in orthopedics and trauma, as a physiotherapist as well, the theory of having scarring building up in a muscular tissue, it is that it could compromise the contractile effect of the muscle.
I believe it
affect it in theory, but we're trying to get TRT. So
there's some people who are afraid of shots and injections, for the oil solution, and also deep in my glutes. The only issues I had were intramuscular abscess, but I didn't care significantly about the scar, rather than the accumulation of the oily solution into my muscles. But
I think the main thing is, if you're worried about that, you have the scrotal cream application that does. Studies do show that it improves absorption right through the scrotum in comparison to other parts of the body. So you do have an option. So you can always speak to the doctor about it.
The scrotal application has a higher DHT conversion.
Yeah.
You think so? Yes.
Well, I think a lot of doctors have tried using bits of cream added to injectable protocols, to scrotal cream, to try and boost DHT, haven't they?
Oh.
How often do you recommend bloods get tested? Every 3 to 6 months?
So I think the guy said, how often is blood tested on TRT? How often do you need to get your blood tested?
Well, when somebody starts using the testosterone, then I advise to my patients to the first follow-up to be within 4 weeks in order to see the blood levels of testosterone, and then if there's no need for any adjustments and modifications, then we have to do it again after 6 months, for instance, and then the annual. The annual also includes the PSA, the prostatic specific antigen, and so yes, the first is the first month to see how is the dosage for us, and afterwards we need the 6 months follow-up and the annual one a year. Now we need also some further evaluations like the biochemicals, some vitamins, also D3, B12, and also the lipids, the liver, the kidney function, also the thyroid panel, also. Yes, as the my hormones also do this. Yeah. It's very important. Yes.
Okay, cool. So this one is: does it matter what age you start TRT? Can you be too old to get benefit or too young?
It's not a trendy thing. it all depends on your condition. I mean, if you're hypogonadic, no matter what, you have to start using it. So there are some people who are supposedly unfortunate to use it before their 30s because of a brain trauma or, you know, of another reason, or Klinefelter syndrome, that these teenagers that they have to use it for life, which is primary hypogonadism. While there are other people who are still in their 40s, they have mid-range of testosterone about 400. They still can manage this, but at their 50s, they cannot. They can barely live with those levels because they have an demanding lifestyle, and then they have to go. I believe it's purely depending on the person, you know, and on the kind of life he has, but also in his medical condition, first of all.
Okay, so there's no age.
And you have to realize this is something for life. You cannot stop it.
Fair enough. Cool, great. So someone said, I think they've come across a lot of doctors that don't know about this, but it says, is TRT in basic medical training in medical school?
No, not at all. Not at all. Of course, we learn in endocrinology some basic things about the androgens, the estrogens, you know, the male hormones, the female hormones, and some pathology also. Purely, listen, purely the term hypogonadism does not exist in pathology. We never learn of this. Of course, we had the Klinefelter syndrome, but this was something like you're born with it. But no, this decline, as also the adrenal fatigue, they do not exist in medicine. And actually, endocrinologists believe that your HPTA will restart or will be improved, or even the androgenic steroid-induced hypogonadism will, your LH or your testosterone will catch up if you leave steroids away, which is a fault, because every year after the age of 35 or 40, HPTA declines 1%. So in a decade, you have a decline of 10%. So there's no turning back, you know, and we age because our hormones decline. Mm-hmm. This is another reason, of course. So we have to restore the hormones under scientific data and under the perspective of an MD. And of course, it has nothing to do with steroid cycling or getting jacked with the HRT. You know, it's about anti-aging, rejuvenation, longevity, and most of all, physical and mental health.
Yes, that's well. Mike, I think you had, when you first started, a doctor said, correct me if I'm wrong, that they gave him some testosterone because he had low levels. So we'll give you testosterone for what, 12 weeks or something?
Yeah, for 12.
Oh, that's for life, forever.
And then my body was going to just miraculously recover to the level, because it would have sensed that previously high level that he introduced exogenously, which was complete bollocks.
Did he tell you to stop it?
And then he stopped me after 20 weeks.
And it sucked, right?
He said, okay, you're fine now. Your body will dip a bit, and then he said it was like a balloon. You would expand like a balloon, the testosterone levels, and it would deflate, but then your body would somehow remember and
So your body will retain the testosterone that you
it would remember that level in my pituitary. So didn't quite work that way.
It's a homeostatic mechanism. So when you give to the body any kind of hormone, if it's androgen, if it's a thyroid, if it's cortisol, then we shut off. Yeah. Okay, and when you administer testosterone, because you're hypogonadic, imagine that this little testosterone that you have is going to crash. So end of the story.
Yeah,
it's going to be diminished, you know.
Yeah.
So but I think the part that was very frustrating for me, and it still is because we hear it from other clients, are the endocrinologists seem to be very resistant. It's like they don't accept that there could be a problem, that things will just come back on their own, and that's good enough.
Magically, just like that?
Yeah.
Well, you know, we talk about endocrine disrupting chemicals. I think you talked about it before, George, things in the environment, the food.
Yes, the plastic bottles, the xenoestrogens, you know.
Like, I think soya is one as well, isn't it? Soya acts like...
Soya are estrogens, yes.
Pesticides in the food.
Pesticides and, like you say, plastic everywhere. I think lots of our fish that we eat, because of the ocean, contains a lot of...
Too much. Now, the farm fish, they feed them with omega-6 that are inflammatory.
So you're probably better off having farmed...
Yeah, that's why you should buy wild salmon, for instance, and not farm salmon.
Okay, interesting.
And tilapia also. Tilapia are fishes that are very high in omega-6.
Okay, fair enough. They are. Some fishing advice. So this is a basic one, but how common do you think low testosterone is? Do you think it's more common than
Yes, I believe that the 21st century hypogonadism and low fertility are facts, and they are growing. And they are growing because of the lifestyle, the stress, the eating habits. People, they do not have time to exercise, you know, and also the xenoestrogen, as we said, the environmental pollution, the bad nutrition. Then we have to pay more expensive for organic food in order to be less, with chemicals and antibiotics. So I believe it's a growing disease, and also the point that it was a taboo subject for the last years, but it's no longer because actually it was a taboo. Why? Because testosterone and low erectile dysfunction was fragile for the man's ego. Unlike women, they're supposed to do whatever to be the beauty and sexy and to take hormones in order to have sex after menopause. But a guy would go to the urologist and take the magic blue pill. But apparently this didn't solve the sex drive. So you have an erected penile without having the desire to have sex.
Okay, so maybe like it's now more talked about and we're more comfortable.
Yes, so the last decade or at least 5 years, the knowledge comes from the States, you know, and Europe and Greece, of course. We had this kind of hormonophobia, and this began from ignorance. Okay, when you're ignorant, you are phobic to something. Also, the fact that bodybuilders and sportsmen abuse testosterone and anabolic steroids gave the testosterone the bad name of villain. Actually, testosterone is the main androgen that nobody can live without it. If you are hypogonadic, you can live without anabolic steroids, you can live without growth hormone, you can live without, for instance, other things. But if you lack of thyroxine or testosterone, you're gonna die. And there are some endocrinologists that they blame that it's a steroid, anabolic steroid testosterone. It's an androgen with anabolic effects, but actually is what separates men from boys. And it's not a synthetic derivative like the rest of anabolic steroids. It's a familiar hormone, you know, with zero side effects to the lipids or to the liver, unlike the anabolic steroids. Of course, you have to use it under optimization, because even 250 milligrams are super physiological levels, and they may lower HDL, for instance. But testosterone is not a villain, you know. It's the foundation of youth.
Okay, great. So this is interesting. So obviously, antidepressants and anti-anxiety medications are quite common,
yes, right? Yes.
You know. So this person said, if people, I mean, this is commonly happens, right? You know, you go to the GP maybe with symptoms of low testosterone, and you get prescribed an antidepressant or anti-anxiety medication. You then may find out that you need testosterone TRT. So they've asked, can you start TRT whilst taking antidepressant and anti-anxiety medication?
Yeah, this is a good question. Actually, I was using antidepressants before I was hypogonadic. But my assumption is the following, that first of all, antidepressants, SRIs, elevate prolactin. Prolactin leads to anorgasmia and sometimes to erectile dysfunction as well. But the fact that antidepressants give you a lift in your feelings, you know, in your emotions, it comes also, it does the same as testosterone, that improves also self-esteem and self-confidence and even the mood by improving the HT, which is a major antidepressant, by improving estradiol, which is also the joy hormone, through aromatization, by improving also dopamine, which is the reward, gives you the feeling of reward. So I believe the combination of both is gonna maybe trigger you to hypomania. Okay. So I believe you have to take off the SSRIs, because you're gonna even feel better if you are hypogonadic. Okay, will give you a lift if you're hypogonadic. You're gonna feel this transition from being low to optimal. Okay, but if you are optimally use testosterone, you may elevate to super physiological levels or super euphoric feeling. And if you already have the other effect from the antidepressive drugs, then you may trigger to hypomania or mania. Depends on the person.
So I know sometimes the SSRIs or similar drugs are weaned off slowly. Obviously, they're not supposed to be stopped anyway. You always need to chat to your doctor.
Yeah, you have to taper them down.
But then, you know, TRT can help.
But I know people who are on SSRIs and have lower sex drive. They cannot masturbate. You know, they feel they feel castrated, and they feel emotionally they don't care about anything.
It's like a
yeah, numbness. Yes, yes. Neither good, neither bad. So a feeling of nothing, you know, it's crazy. Okay. It's like being castrated emotionally.
Okay. Obviously, they would talk to their doctor anyway that prescribed them it before they.
But I recommended to a friend of mine who is a psychiatrist, and he told me to come and speak in his conference about the benefits of testosterone in the mental status of the hypogonadic man. Mm-hmm. And I told him, what about proviron? Proviron is beneficial for the third age man in order to have sex, okay? Because it elevates DHT. However, DHT is what it misses from the old men. They have not the self-confidence, you know? And I believe it's very beneficial. Of course, it's something that cannot substitute testosterone, but maybe proviron is far better to the mental status, you know, because DHT is a very important hormone for the guy.
Like I found an old study where they compared proviron, nesterolone, against amitriptyline, you know, the tricyclic antidepressant for depression in older men.
Yeah.
I believe proviron had just as a good effect outcome-wise, but with fewer side effects. So that
there are some people with low serotonin, and they have to to adjust their brain chemistry, you know. But there are also people who are depressed. So the egg chicken question is, does hypogonadism lead to depression or depression to hypogonadism? I believe it's hypogonadism will make you depressed for two reasons. Because of low DHT, low dopamine, low estradiol, and because of low testosterone, but also because of low or low sex drive and erectile dysfunction that affects directly the ego of a guy.
What about if someone had like emotional trauma though, or as a kid, maybe it does both. Maybe trauma, stress, poor sleep, all those things. Then
stress also leads to cortisolemia. Cortisolemia is also linked to depression because in depression you have stress, but also too much of cortisol will lower your testosterone levels.
Yeah, so maybe it does both. Maybe depression can cause low testosterone, and maybe the other way around as well.
But for surely, a hypogonadic man is depressed. No doubt about
it. 100%, yeah.
No doubt about it.
Well, I remember when that doctor took me off the testosterone, I was not a depressed person before, and I really was. When I was trying to wait for my levels to recover, which they never did. So I've always believed that hypogonadism.
I had a case today at the office. There was a 30-year-old guy who is a fashion model, you know, good looking. He's a bachelor, and he accidentally abused testosterone, not too much, 250 for three months, for 12 weeks. And afterwards, he did a purely PCT protocol. And now he's hypogonadic with 250 testosterone, you know. And so I told him that I'm going to give you another chance with a proper PCT protocol. But if by the new year you're not recovered, you have to consider introducing testosterone because you are an alpha male. He does photo shooting. He does runaway fashion shows. You know, he works in the television. He has to be ripped also. But the only thing that concerns him is fertility. So I told him, no problem. You're going to use alongside your HCG. And when you really want to have the kid, you're going to introduce also the HMG, the synthetic FSH. But, you know, it's a lifetime decision. And he's 30, and he has to consider that this is for life. But on the other hand, he cannot wait for forever in order for his natural levels to go up. And I told him, I don't know if you're going to go up to 50% to mid-range, and this is still enough for you to work properly as a guy, you know?
Don't know whether you're going to recover to enough to feel better for him, basically.
Yes.
Quality of life makes a big
difference.
Yes.
That's what also my mentor told me, Massimo Spatini, 5 years ago in Italy. So he told me, you can still wait for your natural production. You can use also clomid, but I'm not sure if this is enough for you to go to the gym, to have sex with your girlfriend, you know, to feel very good. So you have this, but also you have testosterone that will solve the problem.
Okay, so it's about how you feel, basically, whether your symptoms recover.
Yes.
Okay, great. You got any other questions? I think that was it from our list. So
but we hope we get other questions from other people watching.
So if you've got any other questions, guys, you can leave them in the comments, you know, at the bottom of the video. We collect some more as well. thank you for tuning in again. Thanks.
I have a point to make. I started using the HCG after 18 weeks because my CAM load was really low, my ejaculation volume. So I'm using at the moment 250 twice a week. So 500 I use once weekly. Yeah. And what I realized from the very first day, I had huge morning erections, you know,
with HCG,
and much more sexual desire.
Some guys before that, definitely.
Yeah, and I stopped it because the pregnil was no longer manufactured. So now we have to use Ovitrel. And I was really not satisfied with my testicular volume and also with my ejaculation volume. So yes, I'm introducing this, and as Dr. Touliatos said, the best HRT is to use different hormones. So testosterone, HCG, DHT, DHEA, growth hormone, thyroxine, you know. So the blend of hormones is giving the supreme HRT, not just using only testosterone.
Balance.
The
balance. Yes.
No pun intended. Well, on that note, though, that's interesting. When you said your ejaculate volume increased, why do you think that is? Because sometimes we'll hear some men their ejaculate volume decreases when they start on TRT. So
yes, because there is a shrinkage.
With HCG, it's come back.
Yes.
What do you think the mechanism is? Why does it?
It's about the Sertoli cells and the Leydig cells, and also the shrinkage will go back with HCG through the endogenous testosterone that it will elevate. So HCG keeps your endogenous production to be still on.
So just the question is, I've always thought that the largest constituent part of semen is from the prostate gland.
No, actually, I had this question in muscle development. Actually, the prostate gives a very small percentage of seminal fluid, but the semen is produced in the scrotum and epididymis by the Sertoli cells. You know, just the prostate gives a little bit of prostatic fluids, but you can still have sex without the prostate. The point is, after the surgical procedure, you remove it. You have to be very careful about the plexus over there in the pelvis, because if you damage the nerves, then you damage also the response and the reflex to the erectile, to the erection. You know, the testes produce the semen, you know, and the spermatozoa, but also prostate contributes to the some of the fluid, of the ejaculation fluid. Yes.
Yeah.
To a lesser degree.
Okay, we've definitely had that. The guys, when they've started HCG, some guys don't get on with it at all, but some guys, when they've started it, they've said that they have larger ejaculation.
Actually, I had a patient who was a porn star, very young, you know, and he told me, "Doctor, I want to be more aggressive, you know." Maybe he was abusing steroids and he had a little bit of semen. So I told him use both Ovitrel and Merioforte. So he was really, he was really satisfied after with the result.
He got
and also, his fertility was elevated. He later pregnant also some girlfriends.
Okay, cool. That's interesting. Yeah, let us know how it goes. Let us know how the progress goes with that, whether it sustains.
Yeah.
Awesome. So, we done? Any more?
I think that's it.
Yeah, we got all the questions. So, yeah, thanks again, George, for joining us. We'll do another video soon. Yes. Obviously, like we said before, just hit the microphone again. We've got George's book, you know, bodybuilding, the good, bad, and the ugly. Lots of information in there, really, really good. Obviously, you know, on the back of George's thing, we don't have it on here, but you can go to balanceforhormones.co.uk if you want to speak to us about seeing a doctor. You can see George. So yeah, just reach out to us. If you like these videos, obviously click the like button, subscribe, turn on the notification bell. Yes, no, yeah, and tune in for more. And like I say, if there's any other questions, pop them in the comments underneath.
Oh, they can also go to a Facebook group if they want more information. George is on there as well. Yeah. So you can go to our website and you can click on the Facebook icon and go to the group.
Yeah. If you have any questions, reach out to us anyway. You can always give us a call or go and chat on our website. But yeah, thanks for coming on, George.
Thanks, George.